We will be discussing specifically inguinal hernias, but before we discuss inguinal hernias, let's be sure we understand what the generic term hernia means. A hernia is any time a structure that should be within some kind of a surrounding container, or it's some kind of a containing layer, gets out of that containing layer, we call that a hernia. Earlier in our discussion, we talked about a hernia of the nucleus pulposus when we discussed the intervertebral discs. And we said that the nucleus pulposus is surrounded by the annulus fibrosus. That's the containing wall of the nucleus. So if the nucleus gets out of the surrounding annulus, we called it a hernia of the nucleus pulposus. Similarly, if we have something that should be inside of the abdomen, contained by the abdominal wall, and it gets out of that containing wall, we would call that an abdominal hernia. And we'll name abdominal hernias according to which part of the abdominal wall they come out through. So you can have a hernia coming out through the posterior abdominal wall in the lumbar region, and then you would call it a lumbar hernia. You can have an abdominal hernia projecting upward through the roof of the abdomen, through the diaphragm, and then you would call it a diaphragmatic hernia. If it came out the anterior wall in the umbilical region, we would call it an umbilical hernia. And obviously that means that if it comes out through the anterior wall in the inguinal region, we would call it an inguinal hernia. Now, inguinal hernias are the most common of the abdominal hernias, and therefore that's the one that we will talk about. And inguinal hernias come actually in two different types. They're called indirect inguinal hernias and direct inguinal hernias. And it's important that we understand the difference between them, because not only are they slightly different in their position, they are quite different in their pathway, in their mechanism of herniation. So we want to discuss them separately. First, we'll discuss the indirect inguinal hernia, which really is an easier one for us to understand, because if we understand the pathway for the descent of the testis, which we just discussed, then we understand indirect inguinal hernia, because it is a hernia that follows precisely the same pathway as the previously descending testis did. In other words, an indirect inguinal hernia passes into the deep inguinal ring, runs down the length of the inguinal canal, and will come out through the superficial inguinal ring, traversing the full length of the inguinal canal. So the same pathway that the testis and spermatic cord followed, that's the pathway that some visceral structure, whether it be an organ or a piece of mesentery or some fat, whatever it might be that should be inside the abdomen, will follow the same pathway as the testis previously did, coming out in the deep ring, down the canal, out the superficial ring. Which means that since it's following the same pathway that the testis and spermatic cord followed, it's going to end up in the same position as the testis and spermatic cord. In other words, it will end up in here with the other elements of the spermatic cord, which means it will end up covered by the same 3 layers of fascia that the testis and spermatic cord are covered by. The important concept to have here is that an indirect inguinal hernia is following a pathway that already exists. The inguinal canal is already there, and it's simply going into that deep ring, which is one end of the tunnel, traversing this tunnel or canal, and coming out the other end. So it's following a pre-existing pathway. That is the fundamental difference between an indirect inguinal hernia and a direct inguinal hernia. A direct inguinal hernia does not follow a pre-existing pathway, but rather it makes its own pathway on its way out through the abdominal wall. It literally tears through the abdominal wall, making its own pathway as it goes. Now, if a direct hernia is going to be tearing through the wall, making its own pathway as it goes, one might suspect that there would be no way of predicting where that's going to happen. Since it's tearing through the wall, we might suspect it could tear any place it chooses to, and we couldn't predict it. But in fact, we can predict it, because if it's going to tear through the wall, it's going to tear through the weakest part of the wall in the inguinal region. So how do we figure out where the weakest part of the wall is? Well, when we look at the layers that make up this abdominal wall, the layer that has the greatest strength is this external oblique aponeurosis layer. The external oblique aponeurosis is a very tough collagenous fibrous layer with a great deal of strength. And that's what contributes most of the strength most of the integrity to the abdominal wall. So that means that if there is a place where that external oblique aponeurosis is deficient, where it's missing, that will be a weak spot. And we already know that there is a place where that layer is missing. We call that the superficial inguinal ring, where there is a hole in the external oblique aponeurosis. So that means at the region, at the level of the superficial inguinal ring, that's going to be a weak spot in the abdominal wall. So if a direct hernia is going to be tearing through the wall, we would expect that it would tear through the weakest place, which means it would tear from directly behind the superficial ring and tear and come out through the superficial inguinal ring, tearing its way out as it got there. Okay, so it tears through there, tears through there, tears through there, gets to there, and then it comes out the superficial ring. Now, be aware of what we just said. We just said that the direct inguinal hernia comes out through the superficial inguinal ring. And a few moments ago, we said that an indirect inguinal hernia comes out through the superficial inguinal ring. So both of those statements are true. In other words, both kinds of inguinal hernias, direct and indirect, emerge through the superficial inguinal ring. What's different about them is how they got to the superficial inguinal ring. We previously said that an indirect hernia got to the superficial ring by entering the deep ring, traversing the length of the canal, and then coming out the superficial ring. The direct inguinal hernia does not go through the deep ring. It rather tears through the layers of the abdominal wall behind the superficial ring, tears through these layers, tears through that, finally gets into the canal here, and then comes out through the superficial ring. So direct and indirect inguinal hernias have in common that they both come out through the superficial ring. They're different in that indirects pass out through the deep ring. Direct hernias do not pass through the deep ring. Because the direct hernia is tearing through this layer, the transversalis layer, and it's tearing through the transversus abdominis and internal oblique layers, that means it's not going to be covered by those layers. It's tearing through them, therefore not covered by them. It will enter the canal here and exit the superficial ring, so it will be covered by the outermost layer. So in contrast to the indirect hernia, which we said will end up sitting in here where the elements of the spermatic cord are, and will be covered by the 3 layers of fascia covering the spermatic cord, the direct inguinal hernia will end up between the external spermatic fascia and the cremasteric fascia, not covered by the cremasteric and internal spermatic fascia, but only covered by the external spermatic fascia. It's not covered by these 2 layers because it tore through those 2 layers on its way out. This region where the direct inguinal hernia tears through to get into the canal, through the back wall of the canal to come out through the superficial ring, this region of the inguinal canal has been given the name the inguinal triangle, and that triangle is bounded by the rectus abdominis on the medial side of the triangle, and by these blood vessels, the inferior epigastric artery and vein on the lateral side of the triangle, and then the floor of the triangle will be the inguinal ligament. So what we're saying here, therefore, is that indirect inguinal hernias, because they pass through the deep inguinal ring, are passing through a region that is lateral to the inferior epigastric artery. Whereas a direct inguinal hernia, because it's passing through the inguinal triangle, is passing through a region that is medial to the inferior epigastric artery. And it's that distinction, indirect hernia is passing lateral to the artery and direct hernia is passing medial to the artery, that we can use to distinguish direct from indirect inguinal hernias. Because remember, as we said, both kinds will emerge through the same place, through the superficial inguinal ring. So, how do we use that anatomy to make that distinction? Let's imagine that at the time of surgery, we have a patient who has an inguinal hernia, and the hernia is going to be repaired by an open repair. And so the skin and superficial fascia, layers 1 and 2, are incised, which brings you down to layer 3, which is where the superficial inguinal ring is. And there's a hernial sac emerging through the superficial inguinal ring. So that tells us that it indeed is an inguinal hernia, but it doesn't tell us which kind of inguinal hernia it is. So what you can do at that time is take your finger and push that hernial sac back into the abdominal cavity. And when you push it back in, it will go back in through the same pathway that it came out. So if it's an indirect hernia, when you push it back, you're going to be pushing it back this way, and it will go back through the deep ring. And your finger, of course, will be following it, so your finger is going to be sitting here in the deep ring. The question is, how do you know that your finger is in the deep ring? You can't see that. These other layers are in your way. You can't see the deep ring. So how do you know that you're in the deep ring? Well, when your finger is there, you're going to be able to feel the pulse of that artery, the inferior epigastric artery. And what you'll say to yourself is, I can feel the pulse of the artery on the medial side of my finger, which means that my finger is lateral to the artery. We know that the deep ring is lateral to the artery, and therefore, since we know that only indirect hernias go through the deep ring, that tells me that this is an indirect hernia. On the other hand, if this was a direct hernia, when you take the hernial sac and push it back into the abdomen, it's going to go back this way, the same pathway that it came out through. That way, your finger will end up sitting here in the inguinal triangle. How will you know you're in the inguinal triangle? You can't see it, but again, you'll feel the pulsation of this artery. This time, you'll be saying the pulse of the artery is lateral to my finger, which means my finger is medial to the artery. Well, since I know that the deep ring is lateral to the artery, and I know my finger is medial to the artery, therefore I know I am not in the deep ring. And if I'm not in the deep ring, this must be a direct inguinal hernia, because direct hernias don't go through the deep ring. So it's the position of the hernial sac on its way out through the wall, lateral to that artery or medial to the artery, which will tell you whether it went through the deep ring or did not go through the deep ring, which in turn tells you whether it was an indirect hernia or a direct hernia. Now, that method, as we said, works at the time of surgical repair because we started off by incising the skin and the superficial fascia. What can we do on physical exam when we don't have the ability to make those incisions? So if we look at this slide here, we can draw into it the inguinal canal. Here's the inguinal ligament. There's the pubic tubercle, which is the medial end of the ligament. There's the anterior superior iliac spine, which is the lateral end of the ligament. And the inguinal canal is parallel to and just above the inguinal ligament, the medial half of the inguinal ligament. So the superficial inguinal ring is here, just superolateral to the pubic tubercle. The deep inguinal ring is about here, just above the midpoint of the inguinal canal. So on physical exam, you can palpate the pubic tubercle. You can then place your finger right over the superficial inguinal ring and feel for a hernial sac. And if, when you ask the patient to increase intra-abdominal pressure by coughing, if you feel a hernial sac push out against your finger, you know that that hernia is coming out through the superficial inguinal ring, which tells you it's an inguinal hernia, but it doesn't tell you which kind of inguinal hernia. What you then can do is, before you ask the patient to cough a second time, use your other hand, your non-examining hand, and compress the abdominal wall right above the midpoint of the inguinal ligament. So you're compressing the deep inguinal ring. Leaving your examining finger on the superficial inguinal ring, you then ask the patient to cough again. If the hernial sac doesn't push out that second time, since you already know that there is a hernia, why didn't it push out? It didn't push out because your compression of the deep ring prevented it from coming through the deep ring. And since only indirect inguinal hernias come through the deep ring, you've now established that this is an indirect inguinal hernia. On the other hand, if while you're compressing the deep ring and ask the patient to cough a second time, the hernia pushes out at the superficial inguinal ring and pushes against your finger anyhow, that means your compression of the deep ring had no effect on the hernia. Why? because the hernia wasn't going through the deep ring. And if the hernia wasn't going through the deep ring, that means it's a direct inguinal hernia. So this is a different way of using the same anatomical fact, the fact being that indirect hernias go through the deep ring and direct hernias don't go through the deep ring, even though both kind come out the superficial ring. But this time you're using that fact by compression of the deep ring without having to palpate the pulse of that artery, since obviously you cannot do that on physical exam. Now, in our discussion of the descent of the testis, a layer of the abdominal wall that we did not discuss pertaining to that descent was the peritoneum, the parietal peritoneum, layer number 8. And the reason we didn't discuss it is, as you recall, the testis began in layer 7, in the extraperitoneal layer, and migrated outward. So it was already outside of layer 8, or already outside of the parietal peritoneum. So that was not a layer that was in the way, so we didn't have to deal with it. Even though that's true, there is an event relating to the parietal peritoneum that is relevant to the descent of the testis. And it's illustrated on this diagram. So here we see the testis in its initial position outside of the peritoneum. This sort of pinkish region here represents the peritoneum. The testis is outside of it. And the testis is eventually going to migrate downward into what will become the scrotum down here. This represents the pubis. It's passing over the top of the pubis through the inguinal canal to get into the scrotum. Now, even though the parietal peritoneum is not in the way, what happens is that before the testis descends, so it's not being pushed by the testis, before the testis descends, the parietal peritoneum forms an evagination, a finger-like evagination, which descends through precisely the same pathway, through that same inguinal canal, and gets down to where the scrotum is forming. That evagination of parietal peritoneum that does that is called the processus vaginalis. We see that the processus vaginalis has already descended in this picture into what will become the scrotum. The testis is still here, has not yet descended. After the processus vaginalis descends, then the testis begins to descend, and fundamentally it slides down along the outer surface of the processus vaginalis. It's not inside the processus vaginalis because it's already outside of layer 8. So it slides down along the outer surface of the processus vaginalis and will eventually work its way all the way down to where the scrotum is. Now, if that were to be the end of the story, there would be a problem. And the problem would be that we'd have this open communication between the peritoneal cavity in the abdomen and the scrotum. And because of that open pathway, it would be very easy for loops of bowel up here in the abdominal cavity to follow the same pathway and simply slide down through that evagination. In other words, it would be very easy for hernias to occur. So normally that's not where the story ends. After the processus vaginalis descends, and then after the testis descends, then the proximal part of the processus vaginalis fuses and disappears, this part. The distal part of the processus vaginalis remains unfused and is down in the scrotum. So the distal part of the processus vaginalis remains unfused, is down covering the testis in the scrotum, and takes a new name. It's now called the tunica vaginalis. And the proximal part of the processus vaginalis fuses and then disappears. So that means that the cavity of the tunica vaginalis used to be continuous with the peritoneal cavity, but no longer is continuous. So we've solved that potential problem. So that's what normally happens. But as we've said previously, during development, when layers are supposed to fuse, sometimes they don't fuse or they don't fuse perfectly. So one abnormality that can happen is we can have what's called a persistent processus vaginalis, where that last step, the fusion of the layers of the processus vaginalis, doesn't happen. The testis ends up down in the scrotum, the processus vaginalis remains patent, and so we're left with a continuous a continuity between the peritoneal cavity and the scrotum, and that's called the persistent processus vaginalis. We said the reason that's not a good thing to have happen is that would make it very easy for hernias to occur. And indeed, when kids are born with a persistent processus vaginalis, they are commonly born with a congenital inguinal hernia. And of course, since this is following the same pathway as the descent of the testis, those congenital inguinal hernias will be indirect inguinal hernias. So what we're saying is that congenital inguinal hernia is a result of a persistent processus vaginalis, and we're saying that congenital inguinal hernias are always indirect inguinal hernias. A variation on this theme that can also happen is that when the processus vaginalis fuses, it fuses incompletely. So we can have something like this, where this part fuses as it should, this part fuses as it should, this most distal part is not supposed to fuse, that's what remains as the tunica vaginalis, but perhaps we have a small region here that remains unfused. So you have incomplete fusion of the processus vaginalis, resulting in a fluid-filled cavity somewhere along the length of the spermatocord, and we call that a hydrocele of the spermatocord. So that would present clinically as a fluid-filled lump in the scrotum along the length of the spermatocord, a hydrocele of the spermatocord, and that, as I said, is a result of incomplete fusion of the processus vaginalis. Okay, we're now going to turn our attention to the female inguinal region and take a look at what are the similarities and what are the differences. And in short, the similarities are many. There is really only one significant or two significant differences. But the similarities are that we have exactly the same inguinal canal, we have all of the same layers of the abdominal wall, we have the same superficial inguinal ring, we have the same deep inguinal ring. What's different is what's coming through the inguinal canal and emerging through the superficial inguinal ring, and where does that structure go? So in the male, what comes through the canal and comes out the superficial ring is the spermatocord, and that, of course, goes to the scrotum. In the female, what comes through the inguinal canal and emerges through the superficial inguinal ring is called the round ligament of the uterus, and where that goes to is the labia majora. So we want to try to figure out why is the round ligament there and why is it going to the labia majora? What does that have to do with what we've been looking at? To understand that, we need to understand the embryology of this region. So I'm going to use this illustration that we looked at before, but use it in a somewhat different way. We're looking at an early embryo, early enough that it is not yet differentiated into male or female. So it's called the indifferent stage. So since we don't yet know if it's male or female, we don't know if this gonad is a testis or an ovary, so we'll just call it a gonad. So that's the gonad. It will become a testis or it will become an ovary, depending upon whether this is XX or XY embryo. Then, on the body wall, we see this fold of the body wall. In our previous use of this illustration, we said that this is where the scrotum is going to form, but of course we don't yet know if there will be a scrotum. And this fold is therefore called the labioscrotal fold. Labioscrotal fold, and that name tells us that if this differentiates as a male, that fold will enlarge to become the scrotum. And if this differentiates as a female, that fold will also enlarge, just not as much, and will become the labia majora. So it's called labioscrotal fold, indicating it may become a labia majora or it may become a scrotum. That relationship between two structures that have the same embryonic origin is called homologous. They are homologs. So the labia majora of the female and the scrotum of the male are homologous structures, meaning they have the same embryonic origin, just as the testis of the male and the ovary of the female are homologous structures. Next, we see this thickening of connective tissue, a fibrous band that connects the inferior or caudal pole of the gonad to the body wall at the labioscrotal fold. And to get from the gonad to the body wall, it's passing through the region that subsequently will be called the inguinal canal. And the name of this thickening of this ligament is the caudal genital ligament. The caudal genital ligament runs from the caudal end of the gonad and attaches to the body wall at the labioscrotal fold. And then we'll just add a representative structure on here to represent the arterial supply to the gonad. So this would be, we'll call it the gonadal artery. We don't yet know if it's going to be an ovarian artery or a testicular artery, but it's the blood supply to the gonad. And of course, running with that blood supply to the gonad will also be the venous drainage from the gonad, the lymphatics for the gonad, the nervous for the gonad. If this is male, that's where the duct for the gonad will run as well. Okay, so those structures are all present regardless of whether this is male or female. So we've already said that if this is male, that gonad is going to descend through the inguinal canal and end up down here. And in descending through the inguinal canal, it will drag this gonadal artery and the other vessels with it right along with it. And so the gonad will end up down here in the scrotum, and the gonadal artery and its accompanying structures will be dragged behind and will be occupying the inguinal canal, which would be in this region here, and going down into the scrotum. So in the male, the testis ends up in the scrotum, and the spermatic cord, which is where the gonadal artery and vein and everything else is located, is what's coming through the canal and emerging through the superficial ring to get down to the scrotum. If this is female, the gonad, although it descends a little bit from the abdomen into the pelvis, does not descend very far. It does not descend through the inguinal canal. It remains up here in the pelvis. And so in the female, what is left in the inguinal canal is this structure, the caudal genital ligament. And in the female, part of that caudal genital ligament will end up being called the round ligament of the uterus. And so it's the round ligament of the uterus that will be coming through the inguinal canal and emerging through the superficial ring. And because in the female this becomes the labia majora, therefore that ligament will be going to the labia majora. The gonadal artery, or the ovarian artery in this case, will be accompanied by its veins and nerves and lymphatics and will remain in the pelvis within a fold of peritoneum known as the suspensory ligament of the ovary. So the ovarian artery will get to the ovary through the suspensory ligament of the ovary, whereas the testicular artery will get to the testis through the spermatic cord, which has been pulled down with the descent of the testis. So the structures are fundamentally the same. The only thing that's different is that because in the male the testis descends, this structure, which is represented by this gonadal artery here, is what gets pulled behind and is left in the inguinal canal. And in the female, since the ovary doesn't descend, it's this structure that's left in the inguinal canal. In the male, this structure ends up down here in the scrotum along with the testis and ends up being called the gubernaculum and is still attaching the testis to the wall of the scrotum. So in the male, the caudal genital ligament becomes the gubernaculum testis, is in the scrotum with the testis, and is attaching the testis to the wall of the scrotum. So we can summarize what we've just said on this slide by saying that in the male, the gonad will become the testis, the caudal genital ligament will become the gubernaculum, the labioscrotal fold will become the scrotum, and the gonadal artery, or now testicular artery, will reach the testis in the spermatic cord. Whereas in the female, the gonad will become the ovary, the caudal genital ligament will become the round ligament, the labioscrotal fold will become the labia majora, and the gonadal, or now ovarian artery, will reach the ovary in the suspensory ligament of the ovary. So the structures are fundamentally the same, their names are different, and their adult position are somewhat different only because the testis descended whereas the ovary did not. The last point to be made about this general region before we move on to the abdominal viscera is to take a look at one other kind of groin hernia. There's another kind of hernia that forms in the groin called a femoral hernia. Now, a femoral hernia presents clinically as a bulge in the groin in a location very close to where an inguinal hernia presents. Recall that we said that the inguinal canal is just above the inguinal ligament. We said that the superficial inguinal ring is right about here. And we said that all inguinal hernias emerge through the superficial inguinal ring. A femoral hernia emerges in this region here through what is called the femoral canal. Now, the femoral canal is an evagination of fascia. The femoral sheath is an evagination of fascia, and that femoral sheath covers the femoral artery and femoral vein and a space without any significant structure in it called the femoral canal. So what's happening is that as the blood supply to the lower limb passes under the inguinal ligament, evaginating the transversalis fascia as it does, that evagination of fascia is called the femoral sheath. The femoral artery and vein, which are the continuations of the external iliac artery and vein, do not occupy that entire femoral sheath. There's a little extra space. That space is called the femoral canal. And abdominal viscera can emerge into that femoral canal and present as a bulge here. So the point that I want to make here is that a femoral hernia, which presents here, and an inguinal hernia, which presents here, will both present as a bulge in the groin very, very close to one another. And the distinguishing characteristic that separates inguinal hernia from femoral hernia is that inguinal hernias exit above the inguinal ligament, where the superficial ring is, and femoral hernias exit below the inguinal ligament, where the femoral canal is. So that since we know the inguinal ligament is attached to the pubic tubercle, on a patient, if you can palpate the pubic tubercle, which you typically can, and then if you can either palpate or approximate where the inguinal ligament is, by determining whether that bulge is just above the ligament or just below the ligament, you may be able to determine whether it is an inguinal hernia or a femoral hernia. Now, you're not always able to do that with a high level of certainty, but that would be the distinguishing characteristic.